shadowing. We will be announcing the winners at the end of today's virtual shadowing session. So you guys can send in your raffle tickets throughout the duration of today's session. You guys can scan the little QR code or you can search it. Again, this mentorship networking event will take place on February 19 to 21. This is a 3-day event. Of course, you don't have to attend all 3 days, but if you do, you can meet with up to 2 established professionals per day of the event, with up to 6 professionals if you want to attend all 3 days. And you guys are more than welcome to attend all 3 days. However, this is an RSVP only, which means it's by invite only, and the only way to get an invitation now is to win the raffle. Alrighty, I'm gonna go ahead and get ready with our starting presentation. So hello everybody, my name is Nina Buzumondo Bernstein and I am the co-founder and CEO of Pre-Health Shadowing. Pre-Health Shadowing is a student-based, student-led nonprofit organization focused on making shadowing opportunities readily accessible to pre-health students during the COVID-19 pandemic. Thank you guys all for joining me today, and I have a couple things that I'd like to touch on before we pass it off to our guest speaker. So since pre-health shadowing allows students from not only places in the US, but all over the world to come together in one common location and learn about different health professions, go ahead and drop in the chat where you guys are zooming from today. Wonderful. Thanks for joining us. Like I said, a couple housekeeping things. We do send out 1 weekly email with all of our lineup for that week, every single guest speaker that we'll have with the registration links and the Zoom codes. So if you guys are interested in receiving this, you're gonna have to sign up your email through our website, prehealthshadowing.com/join-us. Once you do so, you're gonna wanna go back to your email and you're gonna search for pre-health shadowing. Once it pops up, you might have to look in the junk or the spam, or maybe even the promotions folder. But once you find it, you're gonna wanna mark the email as important. By doing so, you are notifying your email that you want it to go directly to the inbox. Another thing that you can do is save pre-health shadowing as a contact, and it'll do a similar thing. We also have some exclusive opportunities. So as you guys are a student within pre-health shadowing, we have some perks that we'd like to share with you. And I'd be touching on a couple of those perks throughout this little startup presentation. We do have closed captioning for all of our live sessions to accommodate students with hearing disability. So part of pre-health shadowing is creating flexible and accessible opportunities, which includes people of all different abilities to join us and work towards their health profession. Pre-health shadowing has partnered with the women-led organization Mask for Mask, which is an organization that donates 4 masks for every 4 purchased. So these are some very high quality masks. They are biodegradable. The packaging is biodegradable. It is not only good looking, there's a bunch of different designs that you can get, but it's also good for the people who cannot provide for themselves during the COVID-19 pandemic. 4 masks will get donated for each 4 mask purchase to a hospital lacking resources, or someone in the homeless community, or really just anybody who doesn't have the means to provide for themselves during this ongoing global pandemic. You can help 2 great organizations at the same time, because if you use the code PHS15 for 15% off of your order, you'll also be donating 10% of those proceeds to help pre-health shadowing stay free for all of our students. We have also partnered with FemHealth, which is holding a Purpose Summit. This is a year-long membership to have access to some amazing insight from these amazing women. This is composed of 19 women who are all founders or CEOs or leaders in healthcare. Some of these women are the founders of multi-million-dollar companies, and one of them was even on Shark Tank. So if you guys want to get in on this, it's a great opportunity. Normally it's about $50, $49 to check out. But we've gotten it down temporarily to $29. So if you guys want to hop on this, like I said, it's $29 for the entire year. So definitely, if you're interested in healthcare, if you're interested in being a leader in healthcare, you got to get on this. You can find the link in our chat, and also it's in our Instagram link tree. All right, so like I said, it is $29. However, we are giving away some free seats to this event. So The rules are as followed. This is through our Instagram. You're going to want to make sure that you're following the Fem Health Project on Instagram, as well as pre-health shadowing. You will have to share the post on your story and tag our accounts. You'll also have to comment 3 people that would be interested in coming to the summit, and we will have 3 winners that will be chosen that will receive a completely free membership for an entire year with Fem Health. We will be posting more information on our Instagram, so be sure to be following us at Pre-Health Shadowing if you are interested in this opportunity. All right, here's another perk. If anybody is studying for the MCAT or any other standardized test that you're going to need for a program, Pre-Health Shadowing has partnered with Kaplan to give you guys some amazing perks. If you put in your email to the link that we just sent in the chat, you will get 10% coupon code off of any Kaplan course. Not only will you get that 10% coupon code, you'll also get some free resources. You'll get some study guides, and it's amazing. All of the things that they give you, like I saw it and I was like, because I'm a student, like I feel you guys. So not only do we have that, but we also have the opportunity to give away a scholarship worth $2,500 for a Kaplan course. So if you guys are interested, be sure to be following us on Instagram. You guys can also use this link that we sent in the chat. Go ahead, put your email in. There's no downside to this. You put your email in and we will send you an email with all of these goods. That is the perk of being with Pre-Health Shadowing. Alrighty, if you guys are interested in getting published, Pre-Health Shadowing has a blog. We do have our editor-in-chief, Muntaha, with us today. Muntaha, would you like to say a couple words about this?
Yes, so with the blogs, you can click that. You can type in the pink link right there on the slide in your browser, and you can write any type of blog post like articles, reflections, or success stories, and you'll get published on the Pre-Health Shadowing website and get your name out there.
Great, thank you so much, Muntaha. All right, this is a QR code. I invite you guys all to pull out your cell phones, go to the camera, and then what you can do is scan this QR code with that camera and it'll pull up a website. Go ahead, click that website and it'll bring you to the Pre-Health Shadowing page. And this is the donate page. As I said, Pre-Health Shadowing is a student-led nonprofit organization, and we rely solely on the contributions from our community to keep us alive. We are working to fight against inequity in health education and promote diversity in the various fields. If you are financially able to donate $1 or $5, maybe even $10, that would make a huge difference and allow us to get more access to students around the world who are really interested in becoming health professionals but cannot achieve their dreams without us. Please help us by being part of the change. If you are unable to donate at this time, no worries. Please send this link out to 5 people that you believe will be able to donate. Thank you all. All right, a little bit more information about our mentorship networking event. If you guys are looking for a mentor, we are having a raffle right now for this event. This is a 3-day event that will take place on February 19 to 21. And you will have the opportunity to get a virtual mentor for life. You can ask them for help with anything. You can learn more about their job. You can shadow them one-on-one. The possibilities are endless and it's completely up to you in that professional. All right, if you guys are interested in helping out, Pre-Health Shadowing is a student-based organization. You guys are more than welcome to get involved. This is something that'll be awesome for any resume, CV application, LinkedIn page, etc. So you guys can become a student volunteer and sign up on our website. You guys can also become a team member, which is a leadership role within Pre-Health Shadowing. For more information, we will be talking about this at the end of the virtual shadowing session today. High schoolers, listen up. We also have a team for you. If you would like to join the Pre-Health Shadowing team as a high schooler, we are working to establish Pre-Health Shadowing as a club on various high school campuses across the US. If you'd like to meet with like-minded students across the US to establish this, go ahead and apply to join our team on our website and indicate that you're interested in high school training for Pre-Health Shadowing. Wonderful. Go ahead and post on your social media if you are joining us today for the live sessions. You can tag us at Pre-Health Shadowing on Instagram, TikTok, Twitter, and Facebook. With Pre-Health Shadowing, students can take a post-shadowing assessment to verify their hours. So I recommend that you guys take good notes and ask our professionals some good questions. Feel free to drop those questions or comments in the chat throughout the session, and members of our student team will be monitoring them, and we'll be sure to ask them during the Q&A portion of today's session. Alrighty, so we are going to go ahead and get started with a couple polling questions. So we can go ahead and release those. Feel free to share your cameras if you guys would like to. It's totally up to you. We welcome you guys. It makes it more as if we were really together. Hi, Dr. Rubal. Do you want to go ahead and share your presentation? We have a couple polling questions that we'll put up, but we can put up the presentation in the meantime, if that's all right.
Absolutely, I'd love to.
Wonderful, thank you. All right, we're gonna go ahead and take a look around the room really quickly. Got a lot from Northeastern America, all right, represent. I'm on the West Coast. That's okay. I love that we got students from everywhere. Our student team is also comprised of students from all across not only the US, but the world. All right, awesome. We can go ahead and launch our second polling question. What healthcare path are you most interested in? All right. I see you guys. All right, almost there. And I just want to know, where are you guys in your education? Oh, this is the first time we got the lowerclassmen representing. Hello. All right, and our very last polling question for right now is in regards to the topic of today. And be honest. Oh. Alrighty, I'm gonna go ahead and release that for you all. Feel free to take a look around the room. Awesome. Well, welcome, Dr. Rubal. Thank you so much for joining us today. It's a pleasure to have you.
Yes, thank you so much for having me. I'm so excited to talk to you all. It's been a minute, but I remember being where you are and just feeling like there's so much that you have to think about and accomplish and consider. And so I really hope to be able to give you an idea of my world and what it means, and also let you know that there's a lot of variety too. So I'm excited to start. And so basically what I do is not the REI clothing company and lifestyle company, although that's what literally everyone thinks when I have it on my white coat, but rather it is reproductive endocrinology and infertility. And I'm going to go into what exactly that means. And I love it, obviously, but I really do believe it represents such a good mixture of complex medical issues that you sit down and delve into, plus being able to work with your hands and really get quicker procedures that are usually very satisfying. We're also going to just talk about just the type of patients I see on a day-to-day basis. What diagnoses does this mean? I think it's really important whenever you're thinking about any aspect in medicine is to take the theoretical that you're hearing now and make it practical. And I mean that by what does a day in the life look like? What does it mean? What does a month look like for me? You know, the perfect avatar refers to the type of patient that we usually see. And I'm going to talk about the type of doctor that may be interested also in REI. I also want to share, obviously there's pros and cons with anything. That's one of my mantras that I tell my patients. And so same thing with this. And we're going to go into that in some detail. I do want to focus in on the path to medicine and specifically to repro, endo, and infertility. And so we're going to also delve into that. new horizons on the field because it is a very rapidly evolving specialty in a lot of ways, as well as practice types that you can consider and a case example to kind of wrap it all up, okay? So I'm excited to hear your questions, but I want to start with, what on earth does reproductive endocrinology even mean? I think it's such a big mouthful of a word. And basically, all endocrine means is the study of hormones. The fact that our body needs to have messengers from organ to organ, and this is one of the ways it does it. And so reproductive endocrinology just is how those hormones impact your ability to become pregnant or the organs within your reproductive system. It is chock full of feedback loops. And I added that Nancy Drew book because this is what I used to read ad nauseum. And so I really feel like it was a prequel in some ways to the sleuthing that I get to do on a daily basis to try to figure out what hormones have gone awry and how that's impacting this woman. And so with this field, you know, basic science is our muse in a lot of ways, as it obviously is for medicine in general, but specifically in the fellowship and particularly and in your job, you really do need to have a very detailed understanding of what hormones are composed of. You need to understand how assays work. So when we're measuring hormones, there are different tests and different ways to look at those hormone levels. And you really learn that in intricate detail. Biochemistry is also important because we talk all the time about receptors as well as the hormones themselves. And then of course, genetics, very, very intertwined as well, especially when we think about fertility and DNA sequencing and whatnot, okay? I have to tell you, spoiler alert, as I'm gonna detail in my journey specifically and personally, I was never a science person. It's a little odd that I'm sitting here and talking to you from where I am and telling you how much we idolize basic science, but when I was in school, I told you about how much I love to read. I mean, my parents think, I really think my parents thought I had a GI issue because I used to lock myself in the bathroom because it was the only way I could get uninterrupted reading time. And I really loved art history and I loved those type of subjects, and actually had the worst grade of my college career in organic chemistry, which is all very ironic. So anyway, I'm saying this to have you understand that these are things that of course matter. And it's, I think, very interesting when you can apply them clinically. At least that's how I felt in my path. But I also want to let you guys know that none of us are perfect, certainly least of all myself, and that there is always options, even if these don't seem like your jam, okay? Okay, so I think that it's always helpful to give you specifics. And so we're talking about hormones, we're talking about the endocrine system. What on earth does that actually mean? Well, the way I always talk about it with my patients, and when I educate my patients, I go through this physiology of the menstrual cycle that I just want to share with you as well, because I think it really illuminates what I'm talking about, okay? First of all, of course, here's the female reproductive tract. You could see that it's comprised of the uterus in the middle, that reverse triangle, muscular structure with the endometrium within, that's the womb. There are two fallopian tubes on either side that also are nearby the two ovaries, one on each side. And so that is the female reproductive tract in general. And here is an example of one of those feedback loops I was referring to. And again, this may strike fear in the hearts of some. I find it fascinating, but let's talk about and break it down into a more practical way of thinking about this, or the way I think about it in my head. And here is a really old school way of looking at it. I was so impressed with all your QR codes and all of the tech that you guys have. So please, my apologies for this, for this. But basically what we're looking at is a green ovary at the bottom left, okay? And you can see the blue circles within that. And what those represent are follicles. Follicles are where those eggs are contained before they're released from the ovary. There's one egg per follicle, okay? And, you know, when I'm talking to patients, sometimes this is where I'll lose them. because it does seem dry to some. And so what I've done is I have come up with an analogy. And the analogy I use is that I think of those blue follicles as cars. And I think of the egg within as the driver of those cars, you can see in red, okay? And I want you guys to imagine with me that in a woman who is ovulating, there is a race that goes on every single month, okay? You can see the gray starting line and the black finish line, but it's just like any other race. There's only one that can make it, only one follicle that can grow, one egg that can be released and cross that finish line, okay? And so the fuel, if you will, that starts that race comes from the brain. It's follicle stimulating hormone, it's luteinizing hormone, those are the abbreviations you can see up there, but it's really just a fancy way of saying the fuel that starts that race. And you know, they all want to win, they're all madly racing away. And as they race, their exhaust, if you will, is called estrogen, or estradiol is one of the estrogen types. And so basically estradiol has loads of different functions, okay? One of its functions is to go back up to the brain, and it exerts a negative feedback. And so what that actually means is it goes back up and it says, stop, stop, stop. We have plenty of fuel. We don't need any more. And so, you know, the brain says, okay, fine. And it turns down the fuel. And you know who's doing that. It's the one who's winning the race. It's trying to squash its competition. And that's eventually what happens, is that no one else can overtake that lead follicle. And it eventually grows so big, and it has so many receptors that it's developed, and it wins that race, and its egg gets released, okay? And that's what it depicts, is just it turning down that fuel. But the other impact that estrogen has, amongst others, is on the uterine lining. Okay, and so estrogen goes to that endometrium, and you could see here a bit of a busy slide, but I think that it really summarizes things nicely. I'm going to break it down, okay? And so what we were just talking about is what I have in black. That was the pathway that we were seeing, okay? We were seeing the fuel levels, the pink FSH, the pink LH rather, and the purple FSH, okay? And you can then think about it as those hormones going to the ovary, depicted on the top. You could see the ovarian follicle, and then below it, you could see the estrogen and progesterone that form, okay? And then finally, we see the impact that those hormones have on that inner lining of the uterus. The magnification of it is there, okay? And so when we're thinking about it, what I was just describing to you is the end part of that race, okay? The lining gets thicker, as you can see on that very bottom magnification of the endometrium, and it thickens that lining. That's a response to estrogen. And then someone wins that race, and the egg that gets released goes off, and you know, of course, the goal is to combine with sperm to form an embryo. But that empty car, so to speak, that the egg gets released from, that's called the corpus luteum, that starts pumping out a different hormone called progesterone, progestation, pro-pregnancy hormone, okay? And so that hormone goes to the lining down at the bottom, and it makes that lining really receptive to an embryo implanting if you were going to get pregnant that month, okay? But here's the deal. That corpus luteum has a 2-week shelf life, roughly, okay? And so after 2 weeks, if you aren't pregnant, then the corpus luteum dissolves away, and then there's no more progesterone being produced, and there's no more support of the lining, and the lining can't support itself, and so it sheds, and that's your period. Okay, and so that is the menstrual cycle as a whole. And I think it's so important. And again, it just reflects, you know, all those loops and the intricacy and the signaling, but it really also lays the foundation for everything that I do on a day-to-day basis. And I say that because, as I'll talk about later, all the decisions that I make when, for example, we're taking someone through a fertility treatment cycle, I am manipulating what I know about that to yield different outcomes and different results. For example, more eggs, okay, to be matured. And so, so that was the reproductive endocrinology part of it, okay? So remember, there's a whole other part. It's the infertility piece of this. And I find that infertility, it's very interesting because there are different layers to it. So you can take infertility as a very big macro level, and you could bring it into the most micro level possible when we think about the embryo and some of the chemicals and microenvironment milieu that it's within, okay? Infertility is also important in the fact that there are a lot of procedures, okay, involved in terms of when we're evaluating a couple, when we're treating, or as well, and I'm going to go into the detail about that. It does obviously have a lot to do with embryology, but it's applied embryology. So again, it's very interesting, my journey. I actually always thought I was going to be a pediatrician. And I still remember at the beginning of medical school that how difficult I thought embryology was. And I couldn't get it in my head. It's very hard for me to memorize it. And so again, the irony of here I am, and I just feel like once you get on a day-to-day basis and you're interacting with patients and embryologists and staff, it makes sense in a different way than when you're learning it from a book sometimes, at least for me. Infertility also has loads of different treatment cycles and options, and we use bioidentical hormones as well as different medications that, again, mimic a lot of what we just spoke about. And I think of the physician as the exogenous brain in some ways, which I'm going to get into in just a moment. And so macro view, like I was alluding to earlier, is that overall, there are multiple different causes for why people can't get pregnant, unfortunately, right? If you think about it and you looked at that reproductive tract, of course, you need to have eggs in that ovary of sufficient number and quality. Those eggs have to be released. That's that ovulation that we were just talking about. That egg needs to enter an open fallopian tube. There needs to be sperm of sufficient number and movement and normal appearance that make it from the vagina, go up into the tube, meet with the egg in the distal tube. That's where baby forms and then travels through the tube and implants into the wall of the uterus. So there are a lot of places where an issue can arise, okay? And so all we do in our evaluation is focus on each of those areas, okay? But you can see here that there's also a distribution for different causes of fertility issues. And here's just a diagram depicting some of the female factors, okay, that can be involved. So there's lots. Again, we take it down into the micro level, and this is a depiction of an embryo's journey through the fallopian tube and into the uterus, and you could see how rapidly it has to divide. And I also think what's really interesting is how many, it actually takes days for it to go from the tube and to implantation within the endometrial cavity. And so, and during that whole time, there's lots of interactions it's having, obviously, with its environment. So very interesting. And again, you could see how detailed we get. Okay, this is my, again, old school poll question. So not as fancy as the ones that you guys have, but I just want you guys to think about, do you know, what is the chance of pregnancy per month for a woman in her 20s? You know, no infertility, just trying to get pregnant for the first time. Which one of those numbers would you select? And so I think that I ask a lot of my patients this because, my goodness, it seems like, I think everyone says 80%. I would have said 80% before I got into this field. And it's actually 25% chance of pregnancy per month, okay? I do not want anyone to, you know, freak out about this because I know that that can be a little bit hard to see, but I also want to depict that that's, you know, the best case scenario in nature, number one. So it's important, like when I'm talking to patients and I'm explaining pregnancy rates, that this is what we compare things to, number one. But number two, the second question I want you to see is how many couples conceive within the first 6 months of actually trying? And I'm going to give you a minute to look over those numbers. And they may have changed after you saw the first response. But believe it or not, 80% of couples are going to get pregnant in 6 months, okay? So I think that's the thing to also focus on. I don't want, again, you guys to feel scared about fertility in general, but I do think that it's interesting to see the actual numbers and see maybe how it's different from what you thought, okay? When we think about fertility, of course, a huge part of it is treatment of fertility. and we use different biomarkers to monitor a fertility cycle, okay? And so what that means is we actually have a lot of surrogate ways of looking at whether we think that the egg is mature, which is so critically important. By the way, what does egg maturity actually mean? Well, you know, the egg is a really complex cell. It's frozen in the middle of a chromosome division. Remember meiosis 1, right? And maybe some of you guys are learning about this or recalling this. And it's frozen there since before we're born. And it doesn't divide again and complete meiosis 1 and move into meiosis 2 until ovulation. And so can you imagine when we think about maturity of that egg, it's just that that process has occurred, okay? And that's what we use lots of different things like an ultrasound or blood work, or even things like cervical mucus or urine tests or thermometers to look at temperature to give us an idea about whether ovulation has occurred. And it also helps guide us when we're treating patients, for example, in IVF, okay? I'm gonna get into that in a little bit. This relies upon our knowledge of different hormones, and remember how they wax and wane throughout that cycle and what their effects are on the body. So for example, we know that with ultrasound, studies show that the size of the follicle, we can measure it on ultrasound, and that at a follicle's diameter of greater than about 18 millimeters, more or less, that there should be a mature egg within that follicle, okay? The cervical mucus actually changes in response to estrogen initially. It's a fertile type, and then changes after it's exposed to progesterone, and it kind of gets very thick and blocks sperm from entering. And then the basal body temperature, just to give you an idea, is we can use that because we know that progesterone increases actually your body's set point. And that's why we rely on that. So again, the exogenous brain trust of a fertility treatment cycle, what that means is that we care for a woman undergoing fertility treatments, either ovulation induction. What that means is that they aren't ovulating on their own, and we can help induce that to occur. Or what is termed just super ovulation is a prior term that we used to use. What that means is that we can get more than one egg to run that race to ovulation, so to speak, to mature as well. And we're monitoring that happening, okay? And so when we see a patient for something like a fertility treatment cycle, and we say, again, in a woman, for example, who has a issue with their partner's sperm, we may say, okay, well, let's try to increase the number of eggs to 2 or 3 and increase the sperm through a procedure called an intrauterine insemination, or IUI, to increase probability of pregnancy, okay? And so what we'll do is we'll say, come in with your period. We're gonna give you medications. Remember, the medication is the fuel, so we'll give more fuel to get more to win that race. Also remember, what I tell patients is that you're not losing more eggs than you already would have lost that month. We're just simply resurrecting the ones that would otherwise be lost, okay? For something like an egg retrieval during an IVF or in vitro fertilization cycle, they're being seen a lot. You have 4 to 5 visits, even every day or every few days apart. We're monitoring loads of different markers, like I'm saying. And here I just wanted to show you some of the ultrasound images that would be an example like what we see. And I say this because we do ultrasound day in, day out. We ultrasound all the time, okay? And so you can see here what is being measured by those yellow markings are follicles. Those are the follicles we were talking about. Those are those cars, okay? And you can also see that the average size of these are small at less than 10 millimeters. And what that tells me is that that race to ovulation hasn't begun. They're idling at the starting line, if you will, okay? And you can see here during the course of this IVF stimulation or, you know, fertility in treatment cycle, that now the average that is being measured is 11.5. You can see visually it's bigger. And then here you can see that the average is now 20 millimeters. So we know, we presume that the egg within is now mature, and now it would be able to be retrieved through the oocyte harvesting procedure, okay? And so that gives you an idea of the type of ultrasounds that we do and what we're looking at and figuring out. Oh, and then here is the actual size of the ovary itself, and you can see it's 7 centimeters in size. So during these stimulations, the ovaries can become certainly, you know, double their size at least, right? So I thought that this was interesting. It was a really just nice example, I thought, of what a real-time ultrasound would look like. So you could see here the vessels. So those are blood vessels just lateral to the ovary, and you could see the ovary itself in the follicles in different views, okay? Here's why, guys. Ultrasound relies upon an ultrasound wave, and so it takes a slice through tissue, if you will, okay? And that those waves go to the tissue and then bounce back to the probe. And so we have to be moving it to get a 3D picture in our head of what we're looking at. Because if you just look static, like at this image is the uterus. And in this image, here's the front wall of the uterus, okay? By the way, the ultrasound probe is here in the woman's vagina. And then here is the cervix that you can see. Here is the muscle wall of the uterus, and that's the front wall, so the part closest to her abdomen. Here's the top of the uterus, so closest to the head. And here's the back of the uterus, so closest to the back, obviously, okay? And here is a nice thick endometrial lining, or endometrial cavity, if you will. Like I said, that's just one view, but you have to look back and forth, as I'm going to show you in another depiction, to really get an idea and make sure there's nothing going on the sides of the uterus that you should be aware of, okay? And so here, what I find interesting is you could see the uterus, but then look at the bowel. Isn't that interesting that the bowel is just peristalsing as it does, but just a nice way of looking at that, okay? And so here, oh, too bad. I had a egg retrieval example that I will try to get up in a little bit, but unfortunately it's not pulling up right now. But basically for the egg retrieval, when we're doing an IVF cycle, that's another ultrasound guided procedure. It's just like what I showed you. It's a transvaginal ultrasound, but the difference is that the patient typically is in a conscious sedation, so twilight sleep, with medicines through an IV so they don't feel any pain, they don't remember anything that happens. And then when they're in that twilight sleep, what we do is, again, that same ultrasound, but what we do is we put on a probe cover and a guide for a hollow bore needle, very long one. And what we do is we get a very good visualization of that ovary and then watch under ultrasound guidance as we place the needle through the vagina into the ovary and begin to suck out the follicular fluid and the egg within it, okay? And so that is done typically with every follicle we see in both ovaries. And what happens is that needle is connected to a set of tubing and vials. And so it's under suction pressure, it's under a vacuum. And what happens is the follicular fluid is sucked into those vials, and those vials are then passed off to the embryologist. And in real time, while you're doing the procedure, the embryologist is telling you what they're seeing. And hopefully they're seeing an egg per follicle, ideally, that you're going into. And so it's really a very interesting procedure. And typically it takes about half an hour or so to perform, okay? And that can vary a little bit, obviously based on the number of eggs or the follicles that we see, and then also based on the woman's habitus, and if there's any difficulty in seeing well, and obviously you want to be able to see quite well to be able to perform the procedure. Okay, so after those eggs are removed, the eggs are then taken to the embryology lab, and so those are our partners. We work so intimately with embryologists, and so I don't know if any of you are thinking about embryology. It's a really interesting field. And they are doing, talk about procedures. They are doing procedures all day, every day, okay? And they are working and doing micro manipulation, very interesting. And so what that means is the lab is really supposed to mimic a woman's body. And because of that, these embryos and eggs are kept in incubators with very precise measurements of the gases, of temperatures, of contaminants, of the media that they're stored in. Everything is watched incredibly closely, again, because we know that if there's a change in any of this, it could negatively impact the development of that embryo or egg, okay? Like I said, nonstop, they're always doing different procedures. They're either helping harvest the eggs and then performing something called ICSI. ICSI is an acronym for Intra Cytoplasmic Sperm Injection. That's when an embryologist actually takes the sperm, they find one that's moving forward, hopefully, is hopefully shaped normally, and they physically place that sperm into the egg. And by doing that, we can achieve typically a high fertilization rate. They're also freezing eggs, they're freezing embryos and thawing embryos, and they're also performing different biopsy procedures on the embryos themselves. So lots and lots of interesting procedures that the embryologists are always hard at work on. And so you can see that that is some of the procedures I was just describing. And so when we take a patient through an IVF cycle, eventually they'll get to an embryo transfer, hopefully. That's when we place that embryo back into the uterus. And so it is absolutely a team approach. It is something, and what I mean by that is it's a team approach between you and that patient, meaning the number of embryos transferred, when you're going to transfer them, what day, as well as which embryos to transfer. And then it's also a team approach on the side of the staff, because as the physician, when we're doing embryo transfers, we're basically placing a speculum inside the vagina, cleaning it off, and then placing a very small catheter through the vagina, through the cervix, into the uterus, and then gently depositing the embryos within the uterine cavity. And someone else is helping us and actually holding an ultrasound over the abdomen so we can watch everything so precisely. And then of course you have the embryologist bringing in the embryos into the room and ensuring that the embryos were of course placed inside the uterus and they weren't still in the catheter, okay? And so lots of coordination involved. And it's a short procedure, typically less than 30 minutes. Again, these kind of quicker procedures, women are awake, they're typically don't need anesthesia. They usually don't feel anything except for having to use the restroom because we have a nice full bladder, so we can see on the ultrasound transabdominally. And so I hope this kind of gives you guys an idea of what an actual fertility treatment cycle is like and what we're thinking about and how we're approaching the patients. I know a really common question that I get that maybe you guys are wondering about is how do we prevent that embryo from falling out? That is a question I would always get from patients, and I think it's completely valid and understandable being worried about that. And one of my mentors had a beautiful way of thinking about it, and the way he depicted it is that the inside of the uterus is kind of like the inside of a jelly sandwich, and that embryo is a seed within the jelly. And that sandwich is closed. So embryo is not going to fall out, even if you're jumping up and down. And certainly we know that by data and the evidence and pregnancy rates afterwards, okay? All right, so I gave you that kind of walkthrough of an IVF cycle, but what else do we see? I mean, again, infertility and dealing with conditions regarding this of all types is a very common consult, very, very common. Depending on your practice, you can really kind of hone in on different niches within this world though, okay? Of course, unfortunately, recurrent miscarriage is something that we do see as well, okay? As well as anovulation, which means that a woman doesn't ovulate regularly, and so therefore doesn't have regular cycles, regular periods. Abnormal bleeding, also very common, either heavy bleeding, longer bleeding, bleeding apart from periods, okay, things like that. And I would say thyroid disorders is very common too, just based on the fact that having a thyroid disorder is relatively common compared to some of the other issues that we're dealing with. again, there are different niches even within this space. So menopause is certainly something we learn about in fellowship and some people focus in on. Contraception and hormonal contraception, urologic issues. I remember in my fellowship, we had a male clinic. And so we, as an OBGYN, we had to see the male patients, of course. And so I think of the male partners as very much my patients. And so we're dealing with urologists very closely as well. We can see precocious and delayed puberty, as well as congenital uterine or vaginal anomalies, so a change in the shape of the reproductive tract structures. Neuroendocrinology I find super fascinating. That is how our hormones impact mood and mental disorders and all of that, okay? And then, of course, there's overlap with genetics and maternal fetal medicine, as well as cancer, okay? Cancer cases do make up a part of that because of fertility preservation. Okay, so I wanted to go into what procedures we do and show you guys examples because I'm a visual learner, okay? And so again, lots of ultrasound monitored procedures for fertility treatment. We do a saline infusion sonogram. You can do bubble studies and a 3D ultrasound. So let me just show you what that means, okay? Here again is that ultrasound. Oh, sorry, for some reason my my mouse isn't working any longer, but you can see again, the uterus is actually flipped the other way, meaning it's tilted back towards the woman's back. And so you can see that the walls of the uterus are visible, but you can also see that there is some black fluid within that endometrial cavity. The way I think about this is that the uterine walls, remember that space that we were all looking at, that endometrium? It's actually not a true space, it's a potential space. And so what that means is that the uterus is kind of like a deflated balloon. And so the walls lay against each other typically. And so when I'm just looking at a regular ultrasound, I can't always see if there's something like a polyp, which is an overgrowth of tissue that you can see here. Those look like big teeth inside the uterus, or a fibroid. We can't tell always. And the analogy I use is it's kind of like a Mickey Mouse balloon. You can't see that the Mickey Mouse balloon within the balloon is there if it's all deflated. So what we do is we put a small catheter into the lower part of the uterus, and we place just a tiny little bit of salt water, of saline, inside. And then we look around inside with ultrasound. And the saline comes up as black, which you guys can see. And you can also see really clearly that there is not just a nice smooth inner wall that we would expect, but that it's really jagged inside, and that's because of polyps. And so this was a patient of mine, and we did a procedure to help with this. But here is a live view of, sorry, I'm talking over myself, but a live view of that saline infusion sonogram. And so you can see the black salt water that is present inside the uterus. I'm looking in different views. You can see me moving around. You could see that white kind of moving structure, which I presumed was an air bubble. Okay, and so there you go. That's a very typical example. Quick procedure, really satisfying because we get immediate answers. You get to tell the patient exactly what's going on. But what do you do if you do see something on a saline infusion sonogram? Well, you have to, again, you're going to counsel the patient, of course, but most patients opt to get whatever they see inside the uterus removed, and that's done through a procedure called a hysteroscopy, okay, which is a fancy way of saying a camera through the vagina into the uterus. That's basically what it is. And it's done for lots of different things like polyps and fibroids, which are common, scar within the uterus, which is not as common, certain changes in the shape of the uterus, like a uterine septum, or even opening up the fallopian tubes if there's a blockage at its connection with the uterus. You can do a hysteroscopy and thread a catheter through there. And so there's lots of different things we can do for hysteroscopy during a hysteroscopy. And so here's one example. So what you are seeing here is a view from the cervix looking up towards the fundus. And you could see on the top two images, this big ball just in your way, okay? And that actually ended up being a polyp, a large polyp inside this woman's uterine cavity. Clearly seems like it could be an issue in impeding her chance of getting pregnant. And we know that it may, depending on the polyp size, can certainly have a potential negative impact on fertility or potentially increased risk of miscarriage, okay? But the bottom images, you can see actually the openings of her fallopian tubes. You see those very small black circles within, those are her fallopian tubes at the top of the uterus. And so here is another hysteroscopy image. And you could see that this one was a fibroid. You could see again that normal cavity beyond that big ball kind of in the middle of that uterus, okay? And again, on the bottom is another view of that black circle, which is the fallopian tube opening called an ostium. So very interesting. When I was at my prior partnership, I would do hysteroscopies. Oh my goodness. I think I would do hysteroscopies 2 to 4 times a week. Typically in the office. And so patients are awake, it's an hour-long procedure. Again, very, very comfortable usually, and a quick procedure, immediate results, very satisfying. You take care of it, and she gets to go home the same day, and most women felt back to normal, honestly, the next day. So very satisfying procedures as a part of our field. We also do laparoscopy, okay? And what that means is making tiny little incisions in the abdomen and placing different instruments as well as a camera with a light source and inflating the abdomen with gas so that we can see and operate. And this is done for loads of different conditions, including endometriosis or ovarian cysts. We can operate on the tubes or remove fibroids, remove scar. And interestingly enough, what you'll find is, again, I think what's so nice about medicine in general is that you've got options. Some REI practices, they love doing laparoscopies. They do laparoscopies weekly. Others very rarely do it. And so you can really find the place where you fit and you are happy and feeling fulfilled with the type of procedures you want to do, okay? I think that the robot, I'm going to talk about it a little bit later, but it's a really interesting device. And I think heralds this leap into the future of surgery in a lot of ways. So I'll get into that in a bit. Again, just to talk about fertility procedures, I feel like I've addressed these already, but there are loads of them. And so we get to really work with our hands on a daily basis as an REI. And this is a wonderful REI, Dr. Bana Kashani, who very kindly was able to give me this image of an egg retrieval happening. Okay, so you guys can see in real time that there is a follicle. Look, there is the needle going into the follicle. Okay, and you're going to watch. This is a really big follicle, but you'll be able to see eventually that the follicular fluid starts becoming sucked into the tubing, and you could see the follicle collapsing down around that needle. We have to wait till all of the fluid has been retrieved because the egg comes out last typically. And so you'll watch her and you can see the bowel right by it, right? Do you see that bowel kind of moving around, all right? And so she is able to beautifully just take out all the fluid from that follicle. And so next you could see going to a different follicle. Again, this is by moving that ultrasound around. You could see that the needle itself is echogenic, meaning it lights up as white on the ultrasound. Obviously, that's a really good thing because we need to keep track of where that needle is. And so we rely upon, again, creating that 3D map in our head, understanding the anatomy very well, and just having good dexterity to be able to feel the tissues and determine how much pressure to be using, okay? And so this patient had multiple mature follicles. These are, you could see how many lateral to where she is actually working on. But so that is an example of an egg retrieval. I think that for REI, I mean, obviously medicine in general, but for this field in particular, the future is vast. It is a relatively new field, right? A lot of these hormone assays that we use all the time really were developed, I mean, gosh, 50 years ago. And the first IVF baby was less than that. So there's a lot of technology. It's ever evolving. I think that virtual reality surgery, as I was alluding to earlier, the robot already is kind of on that path to it. What that means is there is a console that the doctor sits at away from the patient, typically, and they can operate using this device. And there is an assistant that actually is by the patient, placing the ports and just watching and using and helping with the camera. So I think that, oh my goodness, who knows? One day it could be virtual, just like we're all virtual right now. Very interesting world and lots of possibilities, okay? I think that obviously there's this, it's a little hard to kind of have a blanket statement on anything, including patients. But I will say that usually you're going to be seeing patients that are 18 to 45 years of age. That's not always true. I actually have a lot of patients of mine who are trying to assess why they are having irregular cycles. And so I feel really lucky. I get to see women even younger than this, which I really enjoy. But that is typically the range, okay, for maybe a stereotypical REI center. They are highly motivated. My goodness, I am always so impressed by my patients. They know more than me sometimes. I will tell you, they have researched, they have looked, you know, they're highly motivated. This is an incredibly painful journey in a lot of ways for these women and couples. And they obviously can be very stressed out and are seeking your partnership and your help. And so that's what I love about it, is that you get to walk on this road with them. And you really get to provide some hope and comfort to them, and really guide them to achieving their dreams, you know? So what is a typical day? Well, this is a kind of, again, stereotypical IVF center, REI physician. This is what the day will look like for them. So, and it might be adjusted a little bit, but it is early hours. I'm a night owl, so I had to adjust to it, but hey, there you go. You can adjust to anything. 6:30 a.m. will be your first egg retrieval, okay? And so you'll get there a little earlier than that. Obviously, you'll talk to the patient, you'll see anesthesia, get things prepared, review the chart. Once in a while, if it's a really busy day, you will have even earlier egg retrievals. I think the earliest time I ever had to get in for a procedure like that was maybe 4:45. Why is that? Because we need to give enough time for the embryologists and actually the eggs and embryos to mature appropriately. And so the times are very precisely determined. And so it's not like we can do it in the afternoon. That's not typically something that works, okay? And so that's why we do these really early procedures in the morning. From like 7 to 9 a.m., you'll be doing cycle monitoring. What that means is those ultrasounds I was showing you. For example, you're following fertility treatment cycles. You're seeing a patient even sometimes as quickly as every 10 to 15 minutes, okay? And you're doing the ultrasounds, you're counseling them, you're figuring out the beginning of a plan, which you'll then make the final decisions on later that afternoon once you get their blood results back. Because again, that's an important piece to how their stimulation's going. From, for example, 9 to 10 a.m., you might have more procedures. You'll do some embryo transfers or intrauterine inseminations. And then the rest of your morning will be comprised of consults, okay? And those consults can be anywhere from 20 to 60 minutes in length, and lots of different types of patients, like I was explaining before, okay? For example, after lunch, you might do some office hysteroscopies. We usually block out an hour long for each of those. And then you can end your day with more consults or another embryo transfer, for example. Okay, so that, and then you'll call patients and talk to your team, making decisions about the dose of medication that patient needs to be on, triggering to prepare for an egg retrieval, for example, and talking to patients about how they're the status of their embryos, or again, decisions based on pregnancy, blood results. That's a typical day, okay? I think that it's important to note that the ovaries wait for no one, right? And so it is a field where you go in on the weekends, Like obviously practices vary, but it is pretty common because when you're monitoring these patients, you have to be watching them ever so closely. Holidays are possible. I mean, I absolutely, that I think that it's the case because the ovaries wait for no one. You can sometimes have cases on Sundays even. Usually nights are not devoted to working, though you may be on call, but it is over the phone and it's typically more like medication related questions, things like that, okay? It is not very common to have emergencies, thankfully. And so I would say that maybe the most common type of an emergency would be a post-procedural complication, which is incredibly rare, or an ectopic pregnancy would be something else, or bleeding in pregnancy. Those are the type of things that we have to talk to people right away, typically, okay? So again, a blanket statement, but what kind of person likes REI? Well, we're dichotomous. I think that in some ways you have to be incredibly analytical and anal and detail oriented and wanting to look at every single thing. But at the flip side is this, the other part of our brain, right? You have to also be incredibly empathetic and understanding. And again, and I think sympathetic to the mental and spiritual and emotional parts of this journey for patients. Definitely science nerd, although like I said, you can develop into one. You are someone who likes variety in your day. You don't want to be just doing one thing all day long. You want to be running around and having different types of experiences with patients. Someone who enjoys short procedures with immediate results, who wants both consults, office-based, plus a surgical practice. Again, I really like that I have very compliant patients. I like forming that partnership. I like that I'm going to say something and they will follow my advice. And I appreciate that. That's not always the case in different fields of medicine. And you're someone who wants options. You can have an academic practice or private practice. You could work for a big group. Or like me, I actually left my prior partnership and pursued a very alternative vision in this sphere. So there's a lot of variety, which is really nice, I think. Okay, I will I'm happy to talk to you guys about the path to REI. How are you guys doing? I hope everyone is finding this informative. But I think for the path to REI, oh guys, it is just like the path to where you are today. We all have such different experiences for this final goal. And so I think it's really important to understand that and to celebrate that actually. But just in general, you're going to need to go to college, right? And then after college, which is typically 4 years, you will then go to medical school, which is another 4 years usually, okay? Afterwards, you will apply and get accepted into an OBGYN residency, which is 4 years. And then there's a 3-year Repro Endo Infertility Fellowship after that. It flies by, I promise. But it does seem long when you're on the front end of it, I think. Again, people take time and they take stops, and you can do additional research or find other degrees within this, as I listed. Okay, but what does that mean, right? What's the example? So for me, I'm from Florida. I'm all the way in California. So clearly very lucky with good weather, but I was really lucky to go to this public gifted school. And I just mentioned that not because that's out there or you have to do that by any means, you don't. But I think the most important part of this school was maybe twofold. Number one, they had loads of AP courses. IB is another option, right? And I think that was really good to go into those courses, try your best, try to do well. Of course, give yourself lots of grace, as I'm going to mention later. But it really allows you to continue to be competitive as you're starting to apply, okay? I think the second and probably the most important part of going to that school is that I was surrounded by people who were amazing, who were very motivated, who were always looking forward and wanting to be successful and wanting to do something good with their lives. And I think that really matters. And so I always encourage people to try to surround yourself with people like that, people who help you grow, because it really does, you rise to it, I think. And I know I did for a lot of it. I don't know where I would be if I didn't have some of the friends and influences that I had had throughout my career. I was a I think mediocre is being kind. I was not a good volleyball player, but I did it for a little bit. I don't think I was even able to get on JV. I think that's how bad it was. So, but you know, did it for a year or so. And then I rode in high school, which was amazing and taught me lots about dedication and hard work and fighting through pain. And then orchestra. So those were kind of my extracurriculars that I did. I was really lucky, because I actually, back in those days, and I'm not sure that they exist any longer, but they used to have these honors programs where you can apply from high school and actually get accepted not only into college, but into medical school. They still do have these programs, but I don't think that they're as short as 6 years anymore. And I think it's because, I don't know, but I think that's because you're still trying to figure out what you want and what the realities of medicine look like. And so maybe not everyone really felt like that was the path that was their calling after further kind of reflection upon that. But anyway, I think that if you feel really certain that medicine is for you, I think it was a really, really nice way to decrease some stress during college. Why do I say that? Well, because I really feel, again, so lucky that I got into that program. Because if I didn't, there's no way I'd be sitting here right now. I don't think I wouldn't have gone into medical school. Why? Because in college, you know, I almost wrote on here like my extracurricular was going out. I mean, I really wasn't very focused. I really wasn't doing the things that I'm telling you to do so that you put yourself in a position where you know what you want to do with your career. I feel like the BS was an appropriate degree for me, really, in college. It really was something where I didn't do very well with a lot of my classes. You know, I really kind of skated by a little bit. And so I got really lucky because I was already accepted. And of course there were metrics that I had to follow. So it wasn't like I was failing, but at the same time, it allowed me that flexibility to still kind of pursue medicine. What does that mean for maybe some of you who are in college right now and who aren't in a program where you're automatically accepted? That's the majority of probably you guys, of everyone in the US, right? I would say to you, and I'm going to touch upon this later, that the most important quality in life and in medicine, clinically, and to demonstrate to people whom you're talking to when you're applying, is to let them know that you are resilient and you are not going to give up. And I think that speaks more in a lot of ways than someone who did get maybe into, like I said, someone like me who it's like, oh, well, this person didn't really do all that they could have on that journey. If you're one of those people who's trying your hardest and you're still having issues with your grades, for example, your GPA or whatnot, I think it goes so long of a way to really dig deep and find a niche that you love and do well in it and really explore that. And then also use your application and your letters of rec to explain any maybe parts of your application that might not be quite as strong, okay? And I don't think anyone should ever throw in the towel without trying to get in. Unless you don't like it. And then obviously, great, then you figured that out and that's wonderful, right? Because you need to have peace at the end of the day with what you're doing with your life. But I say that because, and again, I'm jumping forward, but I did well in residency. I certainly, like you can see, the 4 years of medical school, I finally learned like I had to study and I had to do well. And I had to learn this because this was the rest of my life. And I didn't want to do badly by my patients. And so I finally learned an effective studying strategy for me. But I think there's kind of two types of people who go into medicine. I feel like I always would joke about this with my friends. There's a type who go into medicine, they're like, I got this, like they're the type that they are very confident, and good for them, because we need people like that in medicine. But I think that maybe the other half of us are always doubting ourselves and not feeling like we don't want anyone to figure out that maybe we aren't all that we are cracked up to be. And so I think that it's actually what drives us, right? Because you want to become the best you can be, and you want to do your best. But why I'm telling you this is because when I was about to apply for REI, I almost didn't do it, because I felt like, gosh, I don't have any, I really didn't have much research experience. I don't know that I had hardly any research experience. I was always much more passionate about education and teaching and mentoring and patient education and things like that. And so that was really what I loved. And so I remember feeling like I don't even want to apply, because there's no way I'm going to get in. And there's only like 40 spots in the nation. And it's impossible. Like it's just not possible. And I'm so glad I talked to someone. They're like, what's the worst that can happen? And I'm so glad that I did, because here I am. And thankfully I applied, and I had multiple interviews. And, I think that, again, it's very easy to doubt yourself. And so just always try your best, and always try, and don't give up. Okay. So that's my motivational soapbox speech for you all today, because it's super important. All right. So in med school, your first couple of years, you do didactic problem-based learning. You're getting taught, soak it in. Oh my goodness, I wish I could be taught like that again. It's wonderful to have people that are experts teaching you. Our third year, you actually get to see patients and do what you're going to be doing, and it's very exciting. And then fourth year are electives, so you get to do maybe some of the not core specialties, and that is so important, because not everyone's going to want to do internal medicine or OBGYN or surgery or pediatrics, right? We all have varied interests. And so after med school, obviously you're in residency, and that was the OBGYN residency, which is 4 years. I went and I traveled all the way over to California at USC. It was a county program. And so it was a great experience. I would highly always recommend it. It was kind of the mentality, especially back then, because that was in the mid-aughts of see one, do one, teach one. So you really, as an intern, I was in the thick of it, which I love. And so you get to do lots of different rotations. You get to see obstetric patients. So many deliveries. There are fetal surgeries you can, of course, participate in. Ultrasounds, that is a huge part of the OB world. There are different types of gynecologic care that you'll see. So we were in the OR every single week, operating on people. We would have patients as inpatients and urgent cares. I wrote down INDs just because that memory will always be with me. Unfortunately, if people have infected Bartholin cysts, that's something that you have to open, and it's made an impression on me. Or DNCs. Gyn Oncology is this really intensive inpatient and OR skill set, and of course, dealing and helping care for these patients who really just appreciate your support. And then family planning is complex hormonal management and contraception. And then I did that fellowship. Like I said, I thankfully got in and went to a program that I wanted to go to. The interview process is very similar to interviewing for OBGYN residency, in that you travel all over, and you really interview them as much as they're interviewing you, because the programs can be incredibly different. And so another piece of advice that I have for you is that I feel like it's so important, because they're all very regulated. You're going to go to a program that's good, and that will teach you what you need to know to practice the field of medicine you want to practice. But if you are there and you're just not connecting with the residents, you're not connecting with the staff, I would really be very wary, because that is your family. for a long time. Like we had 80-hour work weeks. Like we were there with other people all the time. And I still remember my fourth year, again, the electives and how important it is to really get a sense of different programs in different fields. I did a Gyn Oncology Rotation, and I think I cried more than I've cried to that. It was like an insane amount of just being unhappy and not connecting at all with the people and really questioning, what I wanted to do. And then I did an REI rotation actually at USC and loved it and felt like that those were people I could work with, and it was the right decision. So listen to your gut. You are going to get well educated no matter where you go. Be with people that you like. So with fellowship, our REI 3-year fellowship's divided into clinical and research-based. And so you will be rotating, at least for mine, it was a county program. So we had county patients that were seeking help. We would go to the IVF center and we would be in the operating room weekly as well. So we had lots of OR time in my fellowship. Not everyone is like that. And then of course the research, you got to choose your own project, and there are basic and clinical types of research that you can perform. So I wanted to give this example. This is my husband. And I think this picture is so funny because he looks like he's glowing in it. So I pulled it off of his website. But anyway, the reason why I bring this up is because, again, I feel like sometimes people, you're going to hear what I'm saying. You're like, oh my goodness, I don't know. That's not the path for me. There are multiple ways to get to where we're going to end up with an MD. For him, he did 5 years of undergrad. He actually did college baseball his first year and had a really hard time maintaining the grades that he needed to maintain to try to get into medicine. And so it took an extra year to kind of work on all of that. He did a post-bac year after undergrad. And then thankfully got accepted and decided to take another year during medical school to also get his MBA. And so did 5 more years as well in medicine. We're like the opposite. That's why I brought it up. It's just kind of funny how different we were. We met as interns, by the way, so it all worked out. Then now he worked in an urgent care for a very long time. He's family medicine and did a great county program at Harbor UCLA in Los Angeles. And now he is CEO and a chief medical officer at this nonprofit federally health qualified health center lookalike. So he is doing wonderful work. I think he's doing just amazing things for patients and for his staff. And look at how different that path was. So I want you guys, again, have hope, have faith, work hard, okay? And so I would say that my pearls for you all, I know this is a lot of info and I hope that this is helpful, but my husband actually, when I was asking about this talk, he was on the UC Irvine admissions committee in med school. And I asked him, I said, well, what would be the one thing for me to tell everyone today? And he said, consistency. Yeah, he had 2. He couldn't narrow it down to 1. He said consistency, that who you are on paper is who is sitting in front of that interviewer and who you are in real life. And that that's really important. Of course, that's important. You don't want to fake, like pretend that you looked into medicine and you haven't even really, you don't even know what it's all about, okay? But even more than that, I think also it allows you to determine whether this is for you. And the second thing that we were kind of talking about and agreeing on is that, again, there are so many paths, as you can see, but then not only after MD, there's so many possibilities afterwards and after you get in, and you don't have to do clinical medicine. Again, give yourself grace. That's one of my biggest mantras. You have to find joy in the here and now and find balance, because that's an important part of life and in being happy, okay? And so just to end, I have some actionable items that I thought would be just important to hear at each stage. And so for high school, I think that a 2-pronged approach is good. You should try to cast a wide net, do things that look interesting, and kind of try to figure out where you are, what you want to try to do, but then really try to delve deep into the ones that you are the most interested in. I think, again, it's a really good opportunity for volunteering, as I said before, and enjoy your family, enjoy the support of having your parents care for you and having, hopefully maybe someone do your laundry, and just the kind of ease that you get when you're still living at home. Okay, and enjoy your friends and have fun. In college, figure out how to study. I told you I didn't figure it out till med school, and I was so behind. I wish I had really figured out an effective strategy for me. So important. Again, deepen friendships with people who are going to motivate you to succeed and who aren't competitive at the end of the day. Be resilient. No one is going to get everything handed to them all the time. And so, so important to just really keep moving forward. I think this one is one of the most important ones. Say yes if you can. All my accolades, all the things that I've done, it really wasn't, it was just me being at that time and saying, I'm going to do it, and acquiescing to the request, or being a little motivated and saying, can I take that on? And because of that, I feel like I've built that foundation to here I am today. And it was a lot of little yeses and agreeing to sit here and take this course. You know, like that's a huge yes. You guys should be proud of yourself. That's a step forward. Yeah, find something that you like, be it research, be it volunteering, a unique interest. I mean, whatever suits you, whatever you find, again, joy in. Be kind to yourself, be kind to your patients, be kind to your staff. Don't be afraid to ask questions. I would always be afraid. I didn't want to be labeled like I didn't know what I was talking about. And it was nice to have people I could ask questions of, as opposed to now I got to make a lot of decisions on my own. I do bounce things off of other people, but I miss being able to just have that opportunity to ask questions and know that you could be a legal witness, or you could be a medical writer, or work for a pharmaceutical company or a research-based company, or be an influencer, or whatever it is. Okay, you don't have to use your medical degree to see patients if you decide that is not for you. So I can get into the case study, but guys, how are we doing on time, and what would you like to hear about next?
So we currently have 6 minutes scheduled, but if you're willing to stay, I'm willing to stay.
Yeah, no, I'm happy to. I just hope that this isn't like information overload, right? So okay, perfect. Let's do it. Okay, so quick case study. Just again, it's similar because I think it's going to be an IVF patient. So it's a 33-year-old. She's a G3. She's been pregnant 3 times, but P0, meaning she doesn't have any children. And she comes in with a chief complaint of trying to get pregnant for 2 years. Okay, and so typically these consults are an hour long, and so you're going, well, for me, not for everyone. For me, I'm a little verbose. You can probably tell. And so in your history of present illness, what you find and what's pertinent is that she's got regular cycles in the past with her appropriate biomarkers, but now they're irregular, every couple of months only. She also has severe pain with periods, and she had a history of a prior chlamydia infection, though no PID, okay? And so, sorry, this isn't moving forward. Her endocrine review of systems is significant for significant emotional stress with her job and with this diagnosis, for exercising for hours daily. And the remainder of her history is positive only for a strong family history of thyroid disease and a surgery for an appendicitis that unfortunately ruptured, okay? So let me just stop here. You're already, in my mind, I'm already wondering, why isn't she ovulating? Is the stress or the history of thyroid disease at play here? Because those two things can affect your periods, can affect that feedback loop. And then the last thing I'm wondering is, oh my goodness, what's going on with her tubes? Because you obviously want the tube to be open so egg and sperm can meet, like I said, and risk factors for tubal disease, this is not an absolute, just a risk, but could be things like prior pelvic surgery. Okay, so the appendix is next to the right fallopian tube, and especially if there was a rupture, there was pus in her pelvis, and inflammation that leads to inflammation, and inflammation leads to scarring. Just like when you get a cut in your skin, if it gets infected, you have a higher chance it will scar. Okay, and then plus the pain with the periods could be a signal of endometriosis, which is a simplification is that those cells inside the uterus-ish are now outside of the uterus, and they respond to the hormones from the ovaries. And so they can still cause a lot of inflammation and even scarring. And then the final risk factor for her tubes that I would be thinking of if she's telling me this is the fact that chlamydia and gonorrhea can damage the tube. And so that would be something else I would be thinking of, okay? And so you do lab work. You get lots of different labs. I didn't put them all down because I didn't want to overwhelm everyone, but the ones that were pertinent were that the FSH and LH, remember, that's the fuel coming from the brain, they were low. And so guess what? In times of stress, be it emotional stress, be it physical stress, like working out hours a day, for example, not in everyone, in some, or be it nutritional stressors. So the most extreme example is anorexia or bulimia, for example. The way I explain it to patients is that induces almost like a survival mode in the body, and the brain says, I can't support anyone else. I'm going to turn the race off. And so in women who have significant stressors, you'll see that happen. They stop having periods, they stop ovulating, they have undetectable fuel. Okay. And their estrogen's low because they're not running the race to ovulation, right? So there's no exhaust coming out of those follicles. No one's racing. All right. And so you see that in her. And so I'm already thinking, oh, maybe that's the cause of her irregular cycles now. You also see her TSH is high. Again, another signaling loop. TSH is the signal that comes from the brain and talks to the thyroid gland. So interestingly, though, her thyroid hormone that's getting pumped out by the gland is normal still. It's a negative feedback. Typically, the hormone goes back up to the brain and tells the brain again, we're good, stop making that signal. But she has positive TPO antibodies. What that means is it's a marker of autoimmune attack. We all have immune systems. It's our body's defense system. And why that matters is because that's a good thing. It's designed to protect us, but there can sometimes be friendly fire. And the body can mistakenly identify one of our own as enemy and attack it. And that's what that marker shows you, is that there's an autoimmune condition, the body's attacking the thyroid gland. And as a result, even though the thyroid gland's keeping up with it because there's a normal hormone still being produced, the brain, the TSH, the signaling from the brain, it's almost like the brain shouting at the thyroid because it's having to work really hard to get a normal amount of hormone out. Got it, guys? So that was a little bit of an explanation, but the reason why it matters in this patient is because that can also throw off your periods. And so there's two things going on here for her with her ovulation. Good news, she has a normal number of eggs based on blood tests that were done and her young age. And the semen analysis that you obtained, also normal. There's lots of different parameters we look at, as you can see, okay? And so you also, we would order a hysterosalpingogram, which is a big fancy term. We just usually say HSG. And all that means is that you can see, here is this uterus, okay? And here's a catheter that's used. The catheter is placed through the vagina into the cervix usually, but they have it depicted here in the uterine cavity. And this is done by radiology. And what they'll do is, like I said, they place that catheter in, they put a little bit of dye to illuminate that cavity. They're pushing that dye to hopefully go out the tubes, okay? And they take x-rays. So they use fluoroscopy to do so as that dye is being passed, okay? By the way, some REIs do this. So REIs absolutely perform HSGs. I wasn't trained in my fellowship to do so, but certainly it's a skill that you can learn. It's very similar to the corollary to this that we do, which is that saline infusion sonogram, which I showed you, right? Similar to this, except we use salt water and ultrasound instead of dyes and x-rays. And then to look at the tubes, we use bubbles. We use air bubbles instead of the dye, like I said. And we watch under ultrasound. They look like shooting stars as they're passing through the tubes, okay? Anyway, so she has an HSG done. Remember, we're concerned about her tubes. And here's what this HSG shows. Oh, no, it's not. This isn't what the HSG shows. This is a normal HSG that I just wanted to show you guys, okay? So here are the bones in the pelvis, okay? This is a really big catheter. That's not the typical catheter that we use, but anyway, there's a catheter. Here's the white dye illuminating the inside of the uterine cavity. And then you can see the dye traversing the tubes. This all looks perfectly normal because the tubes are nice and thin until the distal end, and then they spill, meaning dye spilling from the tube into the abdomen, which is good because that means the tube is open. And when that dye spills, it looks smoky. Can you see the smokiness of it illuminating the outer contours of the bowel? Right? So this is a normal HSG. The shape of the uterus looks good. There's no filling defects within the uterine cavity that would be worrisome for like a polyp, something inside the uterus essentially. And again, the tube shape and the tube spill normal. And here's hers though, unfortunately. And so here's the earlier view. Again, you can see the bones in her pelvis. Here is the dye coming up, normal uterine shape, normal uterine appearance, and initially looks fine, but you can't see the smokiness at the end. So you can't say initially as you're looking through these images that there is spill, that the tube is open, and then they keep pushing dye. And you could see how swollen those fallopian tubes look, unfortunately. And even despite multiple efforts at increasing the pressure, so you know that it's not a pressure gradient issue, there is no spill of dye into the abdomen, okay? So what are you dealing with, right? What's going on? Well, in her case, it would be what we call a hydrosalpinx, which is a fancy way of saying a swollen closed fallopian tube. Okay, and unfortunately, as I described to you, she did have some risk factors to have damage to her tube. She also has what we call hypothalamic insufficiency, which is the fancy way of saying that emotional stressor that's affecting her hormones, as well as thyroid disease. And so if the tube is closed, the sperm and egg cannot meet. But when the tube is swollen and closed, as in the case with a hydrosalpinx, we know that even with IVF, the data suggest that, again, of course, you can overcome this with IVF, right? That's what IVF was designed to do, is to overcome tubal factor, meaning that, again, we take out the eggs, essentially we take out mature eggs after we get them to mature in the body. We take them out, we combine them with sperm outside the body, we see what embryos are resulted, and we transfer a select number of embryos back inside. That's IVF in a nutshell, right? And so you bypass the tubes. But what has been found is that even despite that, if you leave that swollen closed tube in situ, there is even up to a doubling of miscarriage risk and having of a pregnancy chance. And interestingly enough, once you close off that connection of that tube to the uterus, or you take out the tube completely, those pregnancy and miscarriage risks go back to normal for a woman's age. And so we think, no one's entirely sure why that is, but we worry that the fluid inside there is toxic to the embryo, or there was maybe a mechanical flushing effect of the fluid. Regardless, there's something going on with the tube that is the culprit that's affecting fertility, okay? And so for this patient, what do you do, right? Well, like I tell all my patients, I always want them to know that it is their journey, and that my job is to present all the information, the pros and cons of each approach, so that they can make the decision that they feel most at peace with, because we all have our own lives, right? Okay, so with that being said, all the options possible include removing that tube, like I talked to you, right? Followed by doing IVF with her own eggs, because she had a normal number of eggs. You could, of course, adopt a child or an embryo. If you adopt an embryo, which is possible, okay, and then you carry that pregnancy, but then there would still be a recommendation to get the tube taken care of, right? Because you're carrying the pregnancy. Or you could attempt to do a tubal surgery to try to open the tube. If in some cases, unfortunately, there's a high chance that tube will close back up again and lead to another hydrosalpinx. But those are the three, that's what I would say are the three options for her, okay? In terms of overall how to have a child. And then of course, you want to correct her thyroid disease. There are integrative techniques to deal with this issue with the stressors. Or we can just replace the fuel that she isn't making by giving her exogenous gonadotropins, which is a fancy way of saying one of the medications we have during a stimulation called Menopur is the brand name of it. It's a 1-to-1 ratio of FSH and LH, okay? And so we can just give it back to her, again, that exogenous brain as the physician, and we just dose it to how we think she will respond. Okay, and so, she opts to do the surgery. And here's what I was talking about with that robotic device. Look at this. Isn't that amazing that that's where the surgeon's sitting? And he's looking at this in a 3D view. And there's the assistant near the patient helping place the ports and whatnot. Okay. And so it's just remarkable, I think. Here is a diagram of what an egg retrieval looks like. So what we saw earlier in that video, and this is actually what it's depicting and what we were visualizing. And then after the eggs were removed, the embryologist spearheads watching and monitoring those embryos. They develop in a very orderly fashion over the next few days. And so depending on the lab, they can be graded, okay? And so we look at the number of cells, the symmetry of the cells, if there's any debris within the cells, and we hope that they make it to mature stage, okay? Because not all of them do, unfortunately. But if they do, we believe that this imparts a higher chance that they will yield a pregnancy, okay? And so then either those embryos are biopsied, so the cells within are sampled to screen for chromosomes. That's called pre-implantation genetic testing for aneuploidy, typically, or specific genetic diseases, or they're transferred fresh, or they're frozen and transferred at a later point, okay? Once the embryo is transferred, again, it's an ultrasound guided procedure, very similar to the catheters we've talked about before. But again, we're placing an catheter under ultrasound guidance. So you can see the bladder. Here's the woman's abdomen. Here's that woman's full bladder. It's super uncomfortable. Here's that uterus. Here's the catheter. And again, you can see the air bubbles surrounding the embryo, and it shows up as a bright white light. Okay, and you can watch that being placed as you place the embryo inside the uterine cavity. And so I just wanted to see what you guys thought with the live birth rate per cycle in this young, good prognosis patient. And in fact, it is 50%, okay, that having a baby after this. Of course, getting pregnant is going to be a little bit higher than this, but of course, we also are the most concerned about that, hopefully, very healthy baby, okay? Thank you, guys. Again, I welcome all your questions, and I hope that you found this informative.
So the first question that we have for you, Dr. Rubal, is some people are wondering about some study strategies. You mentioned that you struggled with it during college, and then in med school, you found the way that it wasn't the best for you. So people are looking for recommendations if you have any. Oh
yeah, I'm happy to share mine. I mean, okay, so what I did, I have to repeat things in my head. That's what I do when I teach. I teach very much by the Socratic method, because I think that when you're put on the spot and you remember, that's the way you'll get it into your memory bank. And so for me, what I found was finally successful was going through the text. For example, when we had step 1, or MCAT would be the same example, right? You're always going to have those review books, typically, okay? And it makes it easy in some ways, because that was my backbone and repository of information. And so what I would do is I would use that. I would have the review book open. I would have the textbook or whatever I needed to go into more depth with out. And I would have to write things down in order to remember it. And so I would literally copy, but I would try to summarize in these incredibly tiny columns with lots of different colored ink, the pertinent points within the appropriate review section in that book, in the review book. And so again, for example, when we did step 1, I would do that for each topic. And then, especially for step 1, you had to keep going through things until you memorize it. And so then I would rely only on the review book. So I have to carry on a million different books. And I would highlight the things that I did not know. And then I would go through again, and I probably went through it like 4 times for that huge, big test. But for me, in essence, I had to write things down, and then I had to look at it again and highlight it. And then those were my study notes. And so I would make those notes for any rotation, for example, and have like again, back in the day, you guys have like iPads now. It's so amazing, right? But I would have a stack of papers with very colorful, and I fit like 5 columns on a page because I didn't want to carry on a lot of notes. And that's how I did it.
Thank you. So another student asked, during cycle monitoring, do you feel you are able to fully connect with your patients in those 10 to 15-minute windows, or do you think it's just not enough time?
Yeah, that's such a good question. Well, as my patients can probably tell you, this is why I would run late, especially in those parameters, and actually is also a little bit of a reason again, and one of the reasons that motivated me to leave my prior partnership, because I really love the relationship that I have with my patients. And I think it's so important that they understand what's happening. And it's hard for me to do that in a very short time frame, typically. So to answer that question, depend on the patients. Some patients, they are pros and they already know everything, and they know you, and you have a rapport, and you're just able, like, you're just chatting with them and saying hi to them and giving them the quick update, and they are right there with you and they know exactly what is going on. Other patients, I mean, I said 10 to 15 minutes, and I would sometimes probably spend 40 minutes with one patient because I wanted to make sure they needed a lot more guidance in terms of what was going on, what our plan was, what the prognosis was, and it's just important to give that to them.
Thank you so much for answering that. So one of the questions that we have for you is there a correlation between taking birth control and fertility?
So I think that what you're asking is in terms of the fear that maybe a lot of women have about taking birth control and then decreasing or negatively impacting their fertility in the future. And I'm glad to tell you that that has not been borne out, that we believe that after a woman stops birth control, depending on the method used, for example, birth control pills are one of the most common methods, but that those effects wash out and there's no long-term effects on fertility.
Going off of fertility, there was another student asking, what are the typical health behaviors or lifestyles you see in women with fertility issues, like physical inactivity or any risky behaviors?
Oh yeah, well, this is my love. So what I've done in my practice now is that I really am devoted to a radical reimagining of the fertility world, and to do so by identifying and healing the root causes of fertility, and through an integrative medicine lens. And so I actually just started my fellowship in integrative medicine. I can't get enough of learning, apparently. And so I just started a fellowship as an integrative medicine at the Andrew Weil Center at University of Arizona. So I'm really excited. It's another 2 years. Wish me luck. But so absolutely lifestyle matters. I think that the number one thing I would comment on is that, as I mentioned before, is that so many couples and women are just understandably very stressed about all of this. Listen, and I say that when I say that to people, I don't want them to feel guilty about that stress. I think that that is an totally normal and appropriate and understandable reaction. And it's not their fault. And I also want to emphasize that there is no study that significantly correlates stress with an impact on fertility, unless you lose your periods, like we described in the case. With that being said, there are feedback loops that do explain that stress can impact that hypothalamic pituitary ovarian axis. This cortisol actually can tamp down some of those responses. And so what I tell people is I do want them to focus on that aspect of their life. And the way I present it is that we all have stress. We all have stressors. We've got jobs, we've got lives. I mean, that's not going to change. We can't go into a cave somewhere. That's just not, well, I mean, 2020, but there was still stress even in the cave, right? And so with that being said, I encourage my patients to recenter themselves on a daily basis, and to do so by different means. And that's very personal, be it exercise, usually is a great one. I know in this example, maybe it was becoming pathologic, or acupuncture, I'm actually a huge fan of, or meditation, religion, mindfulness, being out in nature, whatever it is for that person. That's the number one thing I would say I see from that integrative medicine lens. And then of course, sure, with the population, there's always eating habits that we address, or environmental toxins. Physical activity, I guess, runs the gamut. But I would say, again, most of my patients are they're healthy. They're really trying to do a good job taking care of themselves. Again, it's, if anything, it's almost like they've gone so deep down a rabbit hole because they want to improve and they're so motivated that that would be almost more what I would say, as opposed to inactivity.
Yeah, that was really, really informative. Thank you so much. Just let us know when you want us to stop asking questions, because we have a lot of questions, and just let us know if you have somewhere to be and if you want us to stop.
Oh, sure. Yeah, but I can keep going. Like I said, I have one at 5, so I'm here for 12 more minutes.
Okay, perfect. So another question that we had was, when do women typically freeze their eggs? And why do some women have more or less eggs? And how long can the eggs be kept alive or are in good shape?
Yeah, that is like the question. If whoever answers that question, I mean, yeah, that is a very important question in terms of egg number. And the reason for that is because as women, we're born with all our eggs, and that number can go down over time. It does go down over time. This is different than men who produce sperm throughout their lifetimes typically, and don't have significant impacts on the sperm until certainly 50. And even then they're still producing sperm. And not us, unfortunately. And so there's also, unfortunately, no one perfect, easy test that tells us exactly how many eggs we have. We don't have that technology. And so because of that, we have to use different puzzle pieces to get an idea about egg number. Okay. And so the puzzle pieces are age, which is the most important one. And so we know that really at 32 there might be slight decrease in number of eggs, but really at 37, it starts decreasing a little bit more rapidly. And there's another dip at age 40 and then thereafter. So that is primary importance, okay? Other things that give us an idea about egg number include the number of follicles on ultrasound. Remember, those are the cars. We can count those. Remember, as we were going through the ovary, you could actually count through that. And it gives us a rough estimate about egg number. And then finally, we use blood tests to guide us in terms of a very rough estimate about egg number. And those are things like the FSH level. We want it to be less than 10. It's that same analogy to the shouting. If there's not as many eggs around, if it's higher than 10, if you will. And then estradiol needs to be less than 80. So we know it's at the proper part of the cycle. And then finally, anti-Mullerian hormone, or AMH, is produced by the cells that nurture the eggs. And so that one we want to be high, because the more you have eggs, the more therefore the more you'll have AMH, and the more they'll produce AMH, and therefore the higher it's going to be in the blood. And so all those things give us a very rough way. The caveat that I have to say with that is that, again, none of these tests are perfect. And in fact, a lot more of what these tests tell us is a woman's response to stimulation, like in IVF, for example. And so have I seen women who have, by all accounts, a diminished ovarian reserve by all these measures, especially with young age, and they still get pregnant and have babies? Absolutely. You know, I think that's the art of what we do, is that you need to understand that part of it too. In terms of egg freezing, I think, is a decision that I think of like as an insurance policy in some ways. I know that sounds very transactional, but why do I say that? Well, because hopefully you won't ever need to use those eggs, right? Hopefully you don't have any issues getting pregnant. But if you are in a position where you are not sure whether that is going to be something that's happening soon, and you are open to undergoing IVF, undergoing the process of having to create an embryo and have that embryo transferred back in the future, open to the financial ramifications, and of course, like all of the hormonal shifts during a cycle and all of these things, then I do think it's an option that you should think about. So I hope that answers that question. And I'm laughing at OChem giving someone nightmares. I'm right there with you. Me too. Anyway, I don't know where you are on questions.
We have another question. They're asking, do you see patients that have struggled with anorexia in their younger years and they're trying to get pregnant in their later years? What does treatment for them look like, if they have any?
Absolutely, I see that. I'm happy to say that if that was something in the past and is not an active issue, it might just not have any, it's not relevant at that point, okay, which is great news. And that's what's so amazing about the hormones, again, is that these half-lives of these hormones are so short relatively. And so they're constantly being produced. And so something that happened that long ago, like if it was a decade ago and it's completely resolved now, may just not be, again, may not be pertinent, okay? If someone's still actively dealing with this, then certainly that is going to be probably the most important part that we're talking about, because we want that woman to be healthy. It can be very dangerous to have those type of disorders if they're, especially when they're very severe. And certainly there are implications of getting pregnant and having and carrying a baby while you're dealing with that. Does that answer that question? I don't know if that answers that question.
Thank you. So just as a last question, we had an important one. Someone was asking, how do you manage work-life balance as an REI specialist?
You know, this is so important. I forgot to say this during the talk, but you guys, ask this question. When you're in medicine and you're deciding your career, make sure, I was talking with a friend again about this talk, is trying to like canvas everyone and get their opinions on what to tell everyone. And that was one of the things she said. She's like, I really wish I'd known about different specialties that were electives, that weren't core. I would have absolutely chosen one of those. So do your research, dig and find your interest, and then see what part of medicine matches those and reflects those, number one. But then number two, make sure you have a good work-life balance. There is such a bias in, I think there's a bias in academic medicine. Academic medicine is wonderful. You do wonderful things. You impact so many people and patients and students and you research and all these amazing, amazing accolades that you can accomplish. But I think that there is a bias that exists within that world against maybe being private practice, or not be on the tract for tenure or for a professorship, or wanting to have more time with your family and that being your primary focus. Again, this is a huge oversimplification and a stereotype. But I say this because I remember feeling scared in some ways to seem like I was lazy, or I wasn't motivated, or I didn't enjoy medicine by asking, how much are you working, and how is call, and how does that feel being on call 2 times a week when you're 60 and you're in the hospital and it's 3 a.m. Are you tired? Is that hard? And that is so important. As an REI, I think I have a great work-life balance. I think it's one of the, I am biased, but I think it's the best subspecialty within OBGYN for work-life balance as well, to be honest with you, because again, I haven't done overnight call in over a decade. Well, maybe that's not true, but close to it. I get to spend time with my kids and my husband, and I love what I do, and I'm not in the, I wouldn't want to be in the OR for like 8 hours at a time. Like that sounds kind of torturous to me. And so I'm glad I don't have to do like things like that. And even if it isn't something that you love, so my prior position, it was definitely very, very busy, and you had very specific timeframes that you had to see patients in. And the nice thing is, again, guys, if you aren't happy, you change, and you will always adapt to it because you made up your mind to do something. And so I changed. And yeah, there's cons with me opening up my own practice, but I love having the time to talk to patients that I need, and I love connecting with people in a more personal way. So anyway, work-life balance is super important, and it's great as an REI, usually.
Thank you. That was actually very inspiring and very informative as well. So Nina, are you there? Yeah, go ahead.
Perfect. Well, thank you so much. That was amazing. The entire presentation was just absolutely amazing. Thank you so much for joining us and taking the time out of your day.
Oh, I'm so happy to help. Like I said, I just remember being in your shoes. You guys, like I said, I can't commend you enough for taking your time out of a Friday, listening in. That already says something about your ethics and your motivation and your ability to succeed. So very best of luck. Please reach out to me if you guys have questions. Like I get it. I was there. I have a web, my name's not that common. So I'm on a website, I'm on Instagram. Like, please, yes, I'm always happy to field something if you guys are just needing someone's advice. Okay.
Wonderful. Thank you so much. And then for all of my students, if you guys are interested in taking the post-shadowing assessment that we've created, you guys can actually get a certificate for joining us for this wonderful virtual shadowing session today. So I'll go over that. I also do want to announce the winner of today's raffle for the Mentorship Networking event. So congratulations, Juliet. You have won your seat to our Mentorship Networking event on February 19 to 21. If you guys did want to join this event, you guys are more than welcome to follow us on our social media. We'll be doing some giveaways throughout the weekend and next week, and we'll have a full set of raffles for all of our live sessions for the following week. Just some information about the post-shadowing assessment. There are quite a few people on here, so if the website does go down, we recommend that you just exit out, kind of like pull your traffic off of it so that it can restabilize and then try again soon. We will be posting this video on our YouTube and our website if you need a refresher before taking the post-shadowing assessment. But that's just what's happening. If you get like a 502 error, it's because we are a student-led nonprofit organization and we are working to gain enough money to keep our server up for the thousands of students that are joining us. Alrighty, just a little reflection. Like we were discussing a little bit earlier, what inspired you to join us today? That's one of the most important things. What is your why? Why did you even come today? And what part of today's presentation resonated with you? What are your key takeaways? So of course, you guys don't have to turn this in for like credit or anything. This is just for you. You're going to be writing your personal statement soon. So kind of just like a snapshot of however you're feeling right now. Of course, if you do want to share this with us, we will definitely love to hear any of your reflections. You can submit this to our website, prehealthshadowing.com/blog submissions, for a chance to get published on the official Pre-Health Shadowing website. This is great for any CVs, resumes, or applications. You guys can also feature this on your LinkedIn profile. Alrighty, and so I do want to, all right, we went through this. All right, awesome. So we are a student-based, student-led organization. We are taking students to join our student leadership team. So this is a 100% remote opportunity for you to meet with not only like-minded students, but professionals from all over the world. You can gain leadership experience and gain some new skills that you might not have had the chance to otherwise. We have students on our team who are, our editor-in-chief, making video productions, chief of social media, advertisement, marketing, writing grants. So if any of you guys are interested in potentially going into research, bye-bye, thank you so much. If any of you guys are interested in going into research, grant writing is something that would be super awesome for you. So you guys can check all of this out on our website. You guys also can apply to be a volunteer with Pre-Health Shadowing. You can work on your own time for as many or as few hours as you would like. You can make your own schedule. We also have hands-on opportunities with our asynchronous opportunities. We allow students to kind of come up with their own projects. So anything you see within Pre-Health Shadowing is a student-led initiative. And so if you guys have any ideas that you would like to potentially lead, all you have to do is submit a proposal as a volunteer, and you could potentially be the leader of that project. So if you guys want some really easy virtual volunteering hours, you can sign up to join our fundraising team. This is through GoFundMe, and you can track how much money you've raised for pre-health shadowing. We are working to fight against inequity in health education and promote diversity in the various fields. So anything you guys can send out to anybody that you know would be really awesome and help us keep our website up for people all around the world who are aspiring healthcare professionals. Be sure to tag us on social media and use the hashtag #PreHealthShadowing whenever you guys do anything cool. We would love to hear about it. You can get reposted on the official Pre-Health Shadowing account. Be sure to tag us. We are active on TikTok, Instagram, Facebook, and Twitter. Here are some of the upcoming sessions for next week. Of course, we do have a full week of sessions, so check out our website, prehealthshadowing.com/sessions to register. And on Monday, we will be hosting Dr. Saya Nagori, who is actually the founder of Fem Health. And so if any of you guys were interested in attending the Fem Health Summit, she will be talking more about it and more about her journey as a healthcare leader. Alrighty. So now to get your certificate that verifies your virtual shadowing hours, you're going to want to go to our website and find our featured professional for today. Once you find her, you're going to click free take this course, and you'll have 30 minutes and 2 tries to get over a 70% on the post-shadowing assessment. Once you do so, you're going to click Finish Course, and you will have the opportunity to download your certificate immediately. You can also find it at all times in your profile under the Certificates tab. If any of you guys have any questions or experience any technical issues, remember, if you get like a 502 error, just X out and try again later. You do have 2 tries to do this, so we've accommodated for that. Feel free to email us at info@prehealthshadowing.com. Okay, this marks the end of our virtual shadowing session today. I hope to see you guys next week. Have a wonderful weekend, and see you soon.